I've shied away many times. I've made a treatment plan for a patient for a quadrant, but I will just work around that upper first molar. We've got that behemoth amalgam because I don't want to touch it. Any help you can give me?
We should not be responsible for owning the clinical problems that a patient presents with.
Most of my patients are above the age of 60 actually nowadays. And when I look into their mouths, I see these huge amalgam restorations. You know, like it's MODB. They've got very, very thin cusps. You can see the amalgam shining through. You can see craze lines, crack lines, but they've been there for so many years. They've been there for 2, 3, sometimes even 4 decades. I mean, you look at these studies about longevity of amalgam and composite, and you know, my patients are, the heavy metal generation patients are a living testament to the longevity of amalgam. However, when things go wrong, they can go catastrophically wrong. Like remember when you find secondary caries around amalgam, it can be a huge, huge mess. And of course, we know that in time, cusps can fracture around amalgams, and that's like the most common emergency we find, which is when someone just broken off a cusp and lo and behold there's a huge amalgam left behind. So when should you look at an amalgam and say, you know what, I'm going to decide now is a good time to crown this tooth, or now is a good time to remove this amalgam because I worry about secondary caries, or I worry about micro leakage? Because if they've been like this for 30 years, 40 years, and I can't really justify enough a good reason to drill into it, then why am I drilling into it? Okay, these are kind of debates that I have with myself. So to help answer this, as part of this Back to Basics series for August, I've got Dr. Andrew Chandrapal from the UK, who is just such a gifted clinician. He's well known throughout the world actually, and I think he's done a really good job of covering this basics of, you know, when do I need to remove this stained composite? Like, is that staining around a margin? How can we prevent it? But then when it happens, do we need to actually drill into it or not? So we covered that kind of theme, but also we talk about that patient who's got these amalgams everywhere, these flat amalgams that they've accumulated over the time, and how we need to manage those patients. But an interesting thing that Dr. Andrew Chandrapal discussed, which I'm going to share with you now as like a teaser for the rest of the episode, is these patients who have a flat amalgam, like, you know, they go from having beautiful cuspal inclines to having this flat amalgam thumbed inside the cavity, right? And then they have another one, and then they have another one, and then they have another one. Eventually, because you're losing the anatomy and the dentist, obviously because it's flat, it's very unlikely that that restoration is finely tuned into the occlusion. So what you get is that every time a restoration is placed, it's out of the occlusion, right? So slowly, but surely, you're losing occlusal vertical dimension. Just imagine all your molars getting these flat amalgams, and eventually each one is out of occlusion, and eventually you lose vertical dimension. And it's interesting how Andrew Chandrapal, who's been very influenced by John Coyce, talks about this constricted envelope that can form. Now, if you don't understand what that means, don't worry. Dr. Andrew Chandrapal will cover that. So yes, this is back to basics theories, but some of it does get a little bit into the bigger picture, which is good. We need to appreciate, we need to look beyond the single tooth and appreciate the bigger picture. So, so much to look forward to in the rest of this episode. I hope you stick around also for the rest of August for the Back to Basics series. I'm hoping, like, if you're watching on YouTube or Dental Tubules or wherever, I hope you like my new setup. I'm now standing, no longer seated. I've got my biggest green screen mounted behind me, so I hope it's coming out okay. For those of you listening, I appreciate you while you're running, jogging, chopping onions, or gardening, whatever you're doing right now. Thanks so much for joining us today. If you're a new listener to Protrusive Dental Podcast, oh my gosh, welcome. Thank you so much for joining us, and stick around, check out some of the older episodes. And just before we join the main meat and potatoes of the episode, I've got my Protrusive Dental Pearl for you. So Raghav Munjal recently on the Protrusive Dental Community Facebook group. That's facebook.com/groups/protrusive. He asked an interesting question. He said, Jazz, you posted a while ago on Instagram about color coding your burs, or dentists that buy or associates that buy their own equipment, and how to make sure it doesn't keep getting lost. Like, that's a huge bugbear of mine. You know, you spend your hard-earned money on buying this equipment or these burs or this, you know, composite brush or whatever, modeling resin, right? And then it gets lost, misplaced, broken, whatever. And it's really, you know, it's really sad because there are these associates who are buying their own equipment. They're growing, but they're few and far between. I think it's a great thing to be able to buy your own stuff sometimes to elevate your dentistry, and then hopefully find a principal that appreciates you enough to buy you the stuff that you want to use. But anyway, when you are that associate and you are buying that stuff, one way I found to make sure that things don't keep getting lost is to color code that equipment. Now, obviously you can't color code your mirrors because that'd be difficult, but you can color code the cassettes that they go into. Or let's talk about, I've got like this little saw, this interproximal saw. If I've ever bonded composite on the adjacent teeth together, so I've stuck the two teeth together, I will use like this little saw. That itself could be a protrusive dental pearl actually. But anyway, use this saw. But that little saw has got a handle, which I've got like this yellow and green tape. So what I'll do is if you go to protrusive.co.uk and if you click on this episode, then I'll put a link there to the Instagram live I did showing you exactly the tape that my nurse uses. So I know that if something is color-coded orange and green, and everyone knows that belongs to me, okay? So it always comes back to my surgery. I've got some hand pieces that are color-coded orange and green, so I know that, hey, these are Jazz's hand pieces, they're gonna go back to him. And when it comes to burs, which is the most annoying thing, the easiest thing to lose is burs, right? So what I did is I bought my own burr blocks from like eBay or something, right? And they're colorful, but I also color code them with the green and orange banding, which again, like I said, if you check out the website, I'll show you exactly where I get that from. And then the burr blocks themselves are color coded. So any burrs I put in will always come back because they're part of that block. And you take a photo of that block. So the decon nurse knows which burrs are supposed to be inside that block. So essentially the pearl is to start getting a little bit savvy with your equipment, look after your equipment. And part of that is actually color coding it, but also telling your team that, hey, this stuff is super important because it belongs to you. So hopefully we can elaborate more on the website when you check out the full Instagram live I did some months ago. Raggy, thanks so much for asking that question on the protrusive dental community. And let's finally join Andrew Chandrapal on what's a very interesting episode about the very fundamental question of when should I drill this amalgam? Andrew Chandrapal, welcome to the Protrusive Dental Podcast, my friend. How are you?
I'm doing really well, thanks, Jazz. Thanks for having me on here.
It is amazing to have you on. Finally, it's something that people have been asking for. Mohammed Sharjeel asked for you. Loads of the others of the Protruserati have asked for you because obviously we've been infected by your enthusiasm in the past. Myself, I first saw you lecture at the BACD. You did a workshop with a microscope and you were teaching us how to do these beautiful lifelike composites. And I saw you again lecture. Again, this is like one of those evening things in the BACD. Again, this was at the BDA on behalf of the BACD. And honestly, your work is always inspiring. So it's great to actually have you on to really, I'm going to try and suck as much knowledge out of you and share it with everyone as possible today.
Yeah, go for it. I mean, it's very complimentary what you have to say. I mean, it's just, it's one of those things that I'm very lucky to be in the position that I'm in. I'm thankful to people who see, what I can what I can offer to the profession and those that believe in me. So I'm privileged to be here.
And to just give us a little bit about your journey, because I think you qualified from Birmingham, right?
Yeah, I'm a Brummie graduate. I qualified 2001. I took a year out and concentrated on trying to focus what I did as an undergrad doing music and stuff like that, because I was a bit of a performer back in the day. So I qualified in 2001. I worked in West Bromwich in the Black Country for a couple of years, developed the accent, so I thought it would be time to leave. Moved down to Oxford into mixed practice there, and then joined a pretty well-known and high-end private practice in Banbury. And then basically moved to Buckinghamshire, which is where I have been ever since. And I've been there for 16 years now. So I spend my time between there and teaching as I do all over the place. And then also in specialist practice in central London now.
Who inspires you? Who inspires Andy?
Oh, that's a good one. So I guess there's kind of mind, body, soul inspiration. So I guess my first inspiration, I can't lie, it's got to be my dad, who's not with us anymore, but he was a massive inspiration to me. We're quite alike, both grafters, both try and do our best to be people persons, as it were. The next one is a guy who taught me as an undergrad. His name was John Davenport, an amazing guy. And he actually, one of the first things he said to me, he said, Andy, you want to make sure that whatever you do professionally, because I can see that you're quite focused on your profession, always have a sideline. Always make sure you do some stuff on the side to give you complete separation from dentistry. Otherwise, it will have this ability to kind of suck you in a little bit. And with that, there's a local park in Birmingham that I was going through that weekend, and I saw him. And bear in mind, John Davenport at that time was probably in his mid-60s, and I saw him rollerblading, just like rollerblading across the park. I'm like, wow, this guy's for real. So he was probably a mind, body, soul mentor. And then clinically, I guess the first time I met Pascal Magnier was 2006, and he changed the way I performed dentistry. He's been massively influential for many dentists, and I know you know him and know of him well. And then John Coyce, who's been my mentor in sort of restorative dentistry, I suppose, since about 2008.
You've been to Seattle a few times to see him, the Coyce program?
I have. I'm a graduate of the Coyce Centre, having done all 9 modules, and I teach the principles on some of my courses. So I fully buy into his approach. It's not a philosophy, so it's not like, oh yeah, you know, I do things the Pankey or the Dawson way or anything like that. It's really based on metric science, and he manages to weed out all the rubbish and keep the good stuff within the science over the last 50 years. And so I love that philosophy. And so his Campbellian thought is always changing and modifying. So I find that makes sense in my little head. So I love that. And then finally, Didier Dietschi is a great friend and mentor in Geneva. He has supported me throughout my career to this point, and is a wonderful clinician and an even better person. And is that type of person that I strive to try and base myself on professionally, and have the integrity that he does. So those are my people.
You have some amazing mentors and friends. Wow, that is so inspirational. That is just so good. I love it. Well, today we're going to be talking a little bit about we're going back to basics. So August is all about back to basics, and I could have picked anything because I know you do teaching on all varieties within dentistry, beautiful composite restorations, the management of tooth wear, and everything in between and wide of that. But the main thing that is actually Mohammed Sharjeel, who just specifically, I don't know why he thought of you, but he said, look, I want to learn this topic and I want to learn it specifically from Andrew Chandrapal. I said, okay, go, what is it? And he said, I want to learn about the management of our day-to-day patients whom, like my patient base is average patients about 60 years old plus, and they have these huge amalgams, right? And he just wanted to hear from you, and he wanted me to bring you on and interview you and ask you questions about how do you manage these big restorations and when they have subjectively failed, because we do see a lot on social media, and we're in a blessed position as young dentists who want to learn that nowadays you couldn't do this maybe 10 years ago, where you can just go on and look and observe and learn from full protocol cases. And there's so much to learn, but there's also something you appreciate, that there's some things that you would do or some things you wouldn't do, other clinicians are doing or not doing. So the classic example is, you know, that restoration that you would have never have touched or replaced and other dentists are replacing. That's it, the classic thing. So essentially, though I'm beating around the bush, but the first crux of the question I'm getting to for you, Andy, is these patients with these large restorations, when do you classify them as failed, and when do you have that? What's going through your mind when you're discussing about, okay, has it neared the end of the restorative cycle?
Okay, great question. Thank you, Mohammed. I think let's take a step back from this, Jazz, for a moment. and if you look at the whole sort of dentition in a single individual for a moment, and you look at someone who's in the age group that you said, that is typical for my kind of age group in general practice as well, you're looking at someone that typically has gone through a restorative cycle of dentistry. That means that there was perhaps a little bit more heavy-handedness for intervention in the eras that have gone before us. So let's look at perhaps the 70s, the 80s, or maybe the early 90s. Typically, these people will be pretty heavily restored. And to give testament to the practitioners of that time, they were doing amalgam restorations, bonded or pinned, that I could never do. I have no idea how these massive MODL amalgam restorations have stayed in place for 20 plus years, because I simply could not do that. And so there is a degree of kudos to practitioners before we start to then change the rhetoric a little bit. But what I will say is that when you have a patient that has a mouthful of these, there is a cycle that's gone before them. And this sort of cyclic fatigue, to me, is the bigger picture. So if we go back to Edwina Kidd's publications and her textbook, in fact, she was then making reference to the fact that amalgam restoration that is leached or ditched to the degree of perhaps 0.5 of a millimeter or more should then be replaced, because you're going to get that sort of creep of material over time, which is going to then plaque, trap, and bacteria, and et cetera, et cetera. So that's one indication, but that's fairly historical. What I'll say is this. If I'm looking at a large restoration that's got facet marks in it, or has got a wide occlusal footprint, as I call it. So in other words, something that shows you that occlusal contact is a wide and flat one, then the potential for that to be adding, especially when you have multiple restorations of that nature, the potential for having loss of posterior guidance, loss of point contacts, loss of posterior bilateral simultaneous contacts is quite high. And what that will do...
As in, what you mean is if you intervene in that scenario, then the risk is high.
Well, what I'm saying is that if the risk is high if we let some of these things go. So the point is of intervening on a single restoration like that is that you have to then conform to that occlusal scheme. And the difficulty with that is that you're adding to the problem. So this kind of cyclic restoration cycle means that every time a restoration like that wears, or every time a restoration is flattened in that sort of way, you lose a little bit of vertical dimension. And that cyclical phase means that you lose vertical and then you increase anterior guidance and increase anterior contact. In other words, get to a point of anterior constrictions being a much higher risk than they would usually be. And that in turn might give you anterior wear as well as the posterior wear that you see. So in short, I'm sorry I've gone around the houses on this, but my indications for replacing something like this is that if I start to see fatigue, early fatigue of a restoration, singular or multiple, then I'll have a look. I'll step back and have a look at the dynamic and the static occlusion as a whole. If I'm suspicious that we've had a loss of vertical as a consequence of that, I will keep a watch on that, perhaps for 6 months. And I'll say to the patient, keep an eye on this. Let's take a scan of your teeth. Let's take a photos of your teeth, or let's take silicon indices, and then let's see if this problem is dynamic. In other words, let's see if the tooth wear is increasing, and then decide, make a pathway to then replace your worn and flattened restorations. Now, whether or not that's amalgam, whether or not that's composite, the principle is the same. Because whenever you're replacing a single restoration, you are having to conform. That's the first thing. I hope that makes sense.
It does, and I'm just going to probe you further on that. But I'm going to let you finish the 2-3 points that you're saying, because I'm really fascinated by this, and I love the angle we're taking here. But I have got some things to try and clarify for the listeners about the decision-making tree. But please do carry on. So if you're, like you said, you might monitor it and see if there's a dynamically deteriorating situation.
Yeah. The second thing is that if I see a restoration within a dentition that does show wear or high occlusal contacts or quite flat, heavy occlusal contacts, I'm always going to be suspicious of fractures within the actual coronal tooth tissue itself. And one of the main things that I am worried about with amalgams that have been present for a long time is what Cameron stated in 1964. And that was that there is a massive concurrence of fractures, sub-restoration, when you remove amalgam restorations. And that's because the amalgam restoration in itself is harder than the tooth substrate by which you put it into. And so that cyclic fatigue that you get on amalgam restorations, the casualty is not the amalgam often, it's the tooth. And so when you unearth these, seeing internal fractures, floor of the cavity fractures, for me, are a real commonality. And sometimes that can be a problem that if we leave it for too long, you're then dealing with problems that could potentially be terminal for the tooth.
But how can you obviously we can't see through the restoration. I mean, yeah, it's very common. You and I both see it. We remove these big amalgams and we see this massive crack line, and we take the obligatory photo so we can explain to the patient afterwards our findings in case it does go necrotic or needs a root canal. But yes, that's one factor. But then how can you predict that? Or is it just a high percentage chance and you go with that in mind?
Well, I think if we rely on percentage chance or probability, I think that we're on shaky ground. I think that that's probably, because I've got an inkling, can we do this? I'm not sure that's going to fly. So actually what I do is try and look at the evidence over a period of time. I'm lucky I've been in the same practice for many years. And so if I'm noting that tooth wear or tooth surface loss is progressive, for example, or this patient presents with lingual or buccal tori, or they have masseter hypertrophy, as an example, I'm thinking, okay, we're building a case for someone who's higher risk. And what we're trying to do here is do a risk assessment on every single patient that comes our way. We're trying to be predictable in terms of our treatment modality so that we don't have a crystal ball, but we can look at the risk factors that would associate with a risk to be higher in one individual than another. And that in itself might legitimize the cause for this individual requiring their amalgam or restoration to be removed, plus a little bit of fatigue that we see on the individual tooth, versus another one that doesn't show any form of dynamic tooth surface loss, shows normal muscle tone, and this type of thing. So there are differences, but you've got to step back from it a little bit and look at the evidence that stands before you. So the term that I was going to point to on my first point, just so you know, Jazz, is it's called a combination syndrome. And combination syndrome is that thing where basically you've got a heavily restored patient who's had, most of their posterior dentition treated directly most of the time or indirectly on some of the time. And over that period of time, the tooth is fatigued, the restorations are fatigued, and we've had that general loss of vertical over that period of time. So every time you do an amalgam restoration or a direct composite restoration, you know what it's like. If you leave it, if you sculpt it in the way that you think or believe is morphologically correct, the patient will be like, you know what, I just can't bring my teeth together on that one side. It feels a bit odd. So what do? You go in and you remove or you adjust as you need to. And then, that feels better. But what you've done right there is conformed or even you've even infra-occluded the restoration, and you're contributing to that combination syndrome. So done over a period of time repeatedly, what that does is further reduces your vertical dimension. And that to me is one of the main rationales as to why a lot of the aged, older restorations that happen to be an amalgam need to be replaced. But you've got to look for the risk size. So you've got to stand back and look at and risk assess that individual patient. Now, going back to the third point, it's a bit more obvious. If I start to see signs of fractures underneath the amalgam restoration, so a lot of the time on premolars, as an example, you might see palatal wall or buccal wall hairline fractures. Some of the time on class 2 restorations that have amalgam restorations, particularly upper fours, you can tend to see these little hairline cracks in between the buccal cusp and the floor of the cavity. So these types of things might be rationales as to why I'd be interventionist and choose to suggest to a patient that you'd remove the amalgam restoration and perhaps then choose to onlay the cusps with your direct composite after that.
That's a clear one to see, and that's a clear one to show the patient as well. One thing I'm going to come back to again in the first time is that it's a much bigger picture issue to convey to a patient, let alone another dentist as well, which, we tend to think tooth by tooth, single tooth dentistry, you replace these restorations. So when you're having this kind of conversation in the future about how flat the tooth is, the functional risk, and being able to convey that to a patient and at a timely manner be able to rehabilitate them to an improved vertical dimension, less constriction anteriorly. So for those maybe dental students listening, if you don't mind clarifying exactly what you mean by the restricted anterior restriction or constriction even.
So the idea is that we can introduce interferences both posteriorly and anteriorly. Now, we know when we learn about occlusion at an undergraduate level, we're taught about the fact that posterior contacts can often be a working side interference or a non-working side interference. And that is often occurring when you excurse. And so as a patient ruminates or masticates their food, as an example, or even protrudes, if you introduce an interference on the posterior teeth, depending on the direction of where the mandible moves, you will introduce a working side or a non-working side interference. Now, as a consequence of that, this is where these working side interferences or non-working side interferences need to be removed, adjusted, or modified appropriately. Now, that can be done subtractively or additively. Now, often the theory stops there. But in fact, when we're talking about interferences, the interferences can also be anterior. So if you can imagine the path of closure, the path of elevation of the mandible as it comes into full closure, into full maximum intercuspation. The issue sometimes is that you can have, and this is well proven throughout science, is that you can have a situation where the mandible elevates into position, has a micro contact onto the incisal edge of the upper incisor teeth, and then shifts back as the mandible shifts. And what you get there is a situation where you can get localized incisal edge wear or palatal incisal edge wear of the uppers and labral incisal edge wear of the lowers. And if you think of a class 2 div 2 type situation where you have kind of frictional wear caused by teeth that are retroclined, if the path of closure of the mandible, which is controlled by the CNS, and that's well proven equally, apart from trauma or pathology, if that closure means that your anterior teeth interfere on that path of closure, then you're going to have an anterior interference, and effectively the mandible is going to be shunted posteriorly distally. And that is known as a constricted envelope of function, because what you are doing is you are constricting the envelope of function, which is the methodology of how the the mandible elevates into its home position, as we call it.
Definitely can hear the course running through your veins, Andy. I love it. I mean, here's an interesting debate I'm going to throw with you, that there are some of my mentors and friends who actually, I wouldn't say they don't believe in it, but they see it in a different way. Let's just talk about that. So there is this, restriction, let's say anteriorly, or a frictional chewing pattern, as is also referred to, which is, am I embarking up the right tree? That it's the same sort of philosophy. Yep.
Yeah.
Now, some people say that actually when we're chewing, and that the teeth generally do not slide, they don't make that contact. And then the way that some other people rationalize that accelerated wear in a class 2 div 2 is, rather than it being a constricted envelope of function, they say it's a constricted envelope of parafunction, i.e. when that patient does parafunction, because of that sort of setup that they have, all the force is transmitted and accelerates the wear anteriorly. Do you have anything in the literature, or from what we know, that could counter that argument in a way, or is this something that we still aren't sure about?
So from what I have learned and from my mentors, the whole definition of parafunction kind of differs, and there is a differentiation of parafunction versus a constricted envelope of function or a frictional chewing pattern. A frictional chewing pattern is not known to necessarily be a parafunctional movement. Parafunctional movements are tending to be classified in my eyes as non-functional movements, and that's the massive difference between those two forms of wear. And so the issue, and let me give you another example. When orthodontics back in the day, I for one, I was a class 2 div 1 case, and I had my upper fours removed. What you end up doing as a consequence of that is retracting in the upper anterior labial segment. But often what you can end up doing is bringing the upper and lower anterior teeth to a minimal or tenuous overjet. And when you have a tenuous overjet, the problem being is that you cannot change the arc of closure as that mandible elevates into position. There are only 3 determinants of that arc of closure. There's the CNS, or your skeletal neuromuscular system, there's pathology, or there's trauma. And so as a consequence of that doesn't necessarily change. And so if the teeth effectively get into that position, or they interfere into that arc of closure, that is an anterior interference. Now, the problem being is that if we are in a situation where our jaw, or rather more our TMJ, can ascertain a position of neutrality within the condyle when our teeth are discluded. So as we are moving our jaws and not in contact, if they're in that position of neutrality, all of a sudden that position of neutrality is then in discord when the teeth meet. And when the anterior teeth meet, you are then shunted. And that therein causes the incisor ledge tooth wear that we're talking about. It's a phenomenon that, it has taken, I guess, a lot of credence, a lot of belief, I suppose, in the more recent years. But actually, when you look back in the literature, it's been there for many, many years. Morton Amsterdam in the 60s was talking about this as an example. Pete Dawson was talking about this for many, many years as an example. And so I guess that you can create an anterior constricted envelope of function by the sheer fact that vertical height can reduce, thereby bringing effectively your anterior teeth closer together. It's the same reason why when we open our vertical height, the mandible postures distally. It's the same reason. So it makes sense that when you lose vertical, the mandible has the ability to posture anteriorly rather than distally when you open it. That makes sense.
Brilliant. And I think that does help to clarify for those listening who've never come across this term. That's great. Now, you've said the 3 points so far. Was there a fourth one, or can I go to the next question?
No, that's it. That's my rationale, really.
Perfect. And I love that so much. And I want to just be able to jump to the next common scenario that you might see. So I think you've gone way over and above what I was expecting. I love that. And you really, and I'm so glad you converted what is a single, it can be interpreted as a single tooth question, but you really, helped everyone to explain that actually you got to take a step back and look at the chewing system, look at the functional risks. So all these great things you've introduced into this dilemma is fantastic. The next question, which maybe is a bit more single tooth based, is that when we see posterior composites and they have the yellow-brown stain, okay, that dreaded stain that you see at the margin, A, how can we prevent that? Any protocols? And B, when these restorations have been there for some time and there's no radiographic evidence of secondary caries, is that in itself a reason to intervene?
Great question. So I think in terms of what we're really looking at is marginal microleakage. So when you start to get a breakdown of the margin of your composite restoration, we are getting a reduction in the hybrid layer, effectively in the adhesion between that thin part of your restoration and the underlying tooth. And so there are a couple of things that are anecdotal. There's a couple of things that are scientific that I can suggest. The first thing I think I will say is that anecdotally is that rubber dam is such an important part of this. Isolation in some way, shape or form to enable the tooth substrate when it's prepped to not get hydrated, to allow the tongue not to contact the cusp tips, let's say, of your tooth prior to restoration is such an important thing. And I think if you're looking at a lower 6 or a lower 7, and you're talking about exactly what you're talking about there, which is marginal breakdown, the chances of that being the case are slightly greater if you're not going to be using any rubber dam isolation. That's the first thing. That said, there is no evidence in the literature that would support the use of rubber dam. And so because it's such a subjective thing. So it's all anecdotal, but there are ways to then apply rubber dam that are simple, that are predictable, that are quick. It's just a case of learning it as we go along, and with confidence, of course. So the second thing I would say is that your prep design is also quite important. Just like something like Emax as an indirect restoration, composite doesn't really like sharp edges. So you need to make sure that you've got beveled edges or that you've got soft edges so that when you have a finish point, it's not necessarily just a butt joint. Equally, if you're sort of overlaying cusps, you need to make sure that that cusp tip on the internal line angle isn't sharp. It's not a butt joint. It needs to be rounded. So things like that will make a big difference.
Before you just jump on to the next one, just a little tip that you can give us when you're cutting your cavities, removing caries, is there a special burr that you use to try and create that sort of bevel or the sort of the correct emergence out into the cavity from the proximal surface?
Sure. So I'm old school, and so I would still tend to use steel rose heads to remove my caries where I can proximally. I sometimes like to finish the proximal boxes with sonic handpieces. NSK do a great sonic handpiece, and the proximal attachments that go with them are really great for removing aprismatic enamel, for ensuring that you don't harm the adjacent proximal wall as well. So we also like using those, but I tend to use rose heads more than anything. I use them with water. So they could be ceramic or they could be steel, but I tend to just go for steel because.
What about for beveling that enamel so you're not ending up with a butt joint of the composite at the proximal?
So when it comes to the actual prep of that particular part, I tend to stick with the 20 micron red band composite finishing burrs, and in particular, I quite like the rugby ball pear shaped burr. I tend to sort of try to flatten that out and then have my handpiece sort of curve over a smidgen so that you've got the bulbosity of that rugby ball that then sort of makes a concavity at that point. So I quite like doing that. I have no hesitation with overlaying cusp tips either. Didier Ditchy did some research that would suggest that posteriorly your composite needs to be at least 1 millimeter in thickness on an occlusal layer. So as a consequence of that, if you're going to overlay your cusp tips, you do need to take that down by at least 1 millimeter in an effort to then overlay and get strength of your composite material. So together with the red band 20 micron finishing burr and at least 1 millimeter reduction on the cusp tip, I'm quite comfortable doing that.
Brilliant. And just leading on from that, at what point do you, numerically or otherwise, are you going to decide to cap that cusp or not? So what's your cutoff point? Do you think, okay, now this cusp is thin enough that I'm going to now remove a little bit to allow 1 millimeter of composite to cap that cusp?
Great question. So I'm going to answer that, and I'm going to go back to the last point that I was going to raise on your first question. So the answer to that is I look at Pascal Manier's research from 2009. He did some finite element analyses on different types of posterior cavities. I'm not sure, you're probably aware of this particular piece of research. And surprise, surprise, what he figured out is that the weakest or the most high stress of type of cavity would be the MOD. And now that stands to reason because, of course, what you've got is a channel going straight through the middle of the tooth. And then you've got these unsupported buccal and lingual walls. So he supported obviously the motion to then say, okay, well, if you don't have to do an MOD and if you don't get rid of that middle part of the isthmus, then don't. And then sort of, get rid of your GB black kind of classification and just do what you need to and then adhere to that, which makes perfect sense. Moving on from that, however, is that what makes me decide whether or not I cover the cusp tips or not is whether the distance between my cusp tips and the width of my isthmus that's been created is the ratio between those two distances. So if the distance between my isthmus that I prepped is over half the distance between my cusp tips, then I will overlay the cusps, if that makes sense. If I'm less than that, then I'm quite happy to not overlay the cusp because I know that the thickness of my buccal or lingual proportions are going to be decent. The only time that changes is if we're diverted onto one side more than the other. And in which case, if I've got a buccal wall that's real thin, but my isthmus is still thin, I'm going to then still overlay that particular cusp tip because it's very thin indeed. That's the only exception. But I will rely on the science to guide me there.
Brilliant. I knew you were going to be coming armed with references and stuff, and I'll try and put as many of these on for the Protrusive Dental Community Facebook group as well, so people can geek out. And you talk about isolation, and you're talking about the correct cavity form, and that led nicely to all these accessory questions. And I think there was one more point you were going to raise, right, in terms of staining.
That's correct. And the other thing that we've got to look at is the quality of the bonding that we get. And one of the main things that we often miss out on is that we think that because the cusp tip is a relatively accessible area in terms of cleaning and hygiene, we think that that's clean. And the difference is actually if you were to use something like GC tri-plaque paste to then highlight your biofilm or some of the plaque, you'd be quite surprised with how much plaque indeed builds up. And so actually what I tend to do is use particle abrasion. Particle abrasion is so important in making sure that your cavities is disinfected, or is at least the biofilm has been removed as best as possible. And I'll overlay that onto the sides, external sides of the buccal and lingual cusps equally, so that when I do perform either a cuspal overlay or I have a finishing point of my composite resin, I know that that's free of biofilm. The same principle will apply from like a class 5 restoration. They look clean, but to the naked eye, they would look clean. But you've got to make sure that you sandblast those areas to make sure you can remove that biofilm. And I found that since I've been using that, and that's been about 10 years now, that has revolutionized the level of marginal leakage that I then get on the periphery of my composite restorations.
But I was having a chat with Marcus Blatz, and he was just coming out with all these evidences for and against aerobrasion. And by against aerobrasion, I mean that there's the lack of efficacy for it. But there's one in terms of bond strength, that is. How much does it really improve your bond strength? And there's some papers for and some papers against. But there's one thing that cannot be denied, and that's the removal of biofilm, which is why I will routinely use it. And I completely agree with you that once you scale and then you actually disclose, you will still find plaque there. But only after you use the aerobrasion unit can you find that you've got a truly clean surface that is ready for bonding. And recently David Jadole came on the podcast and he just blew us away about the two most important things about bonding being clean and rough. So I'm glad you're echoing those same sentiments. So talk about those three main areas of how to prevent having that staining, and how aerobrasion has revolutionized that. So now let's come to the fact that, okay, at what point are you going to see these stained composites, probably not yours, probably from your predecessor, and now decide, okay, now I'm going to intervene because of this staining or this micro leakage?
So that's a tricky one. And I think that there is so much subjectivity that builds into whether or not to decide to intervene because of marginal staining. And it may well be that we have to then communicate effectively with our patients when we do this, because actually it may well be that certain situations don't look terribly complicated or infiltrated with caries, but in fact, when you open them up, they are rife. And it may well be for a host of different reasons. It may well be because the bonding protocol was either old, not so good, perhaps the quality of the bonding agent wasn't ideal back in the day, perhaps the composite wasn't cured in completeness. There's so many factors that can contribute to whether or not you get a propagation of that delamination going all through the tooth. So I guess in answer to your question, I would do this. If I see micro leakage that can either be polished or gently smoothed down by means of either air abrasion or by use of rubber cups, for example, the Shofu One Glosses is a popular one in my hands, or composite finishing burs, and you see a finish that then is not stained or delaminated, then perhaps that's a good place to stop. If, however, you see that then propagating, then obviously you've got to go further in, and you might end up having to then suggest to the patient that you have to remove the whole restoration. The key in the answer to this is really and truly communication with your patient. Because the truth of the matter is that you may not know until you're in that zone. And so you'll have to then make sure the patient has the expectation they're going to have that restoration removed, and the solution presented to them, alongside with the time and the cost and the risks to that patient. And if it's then ever more limited in terms of what you need to do, then that's only then a bonus. And that's a good way to look like the hero.
Brilliant. And we always appreciate these communication gems. And that was one right there. So I really appreciate that. And one thing that we did also touch on, obviously, that you mentioned about the cusp capping, which leads very nicely to the next question, which is, and something I discussed on the podcast at great length with Chris Orr as well, is about at what point do you, Andy, want to go from the beautiful direct work that you do to say, actually, you know what, I'm going to now move to indirect lithium disilicate or whatever for those big restorations. So what is it, because you're so gifted with these composites, for you to recreate function and anatomy of composite comes easy. At what point do you say, you know what, I'm not going to just cusp cap with composite, I'm actually going to now consider an indirect restoration? What parameters go through your mind in that decision making?
Yeah, again, I think the answer to that lies by stepping back and looking at the dynamic and static occlusion by which you're treating. Look at how long that restoration has perhaps been in position, in place, and how well that's performed in the time. Look at the level of fatigue that's in place there. Look at the opposing dentition. Is there anything that you can do to limit the further fatigue of a more simple direct restoration by, for example, removing that of a plunger cusp, for example? Little things like that. The next thing that you need to look at is the ratio of the restoration to the tooth. If you're in excess of about sort of 50 to 60%, then I think there is absolute legitimacy for going for a semi-direct or an indirect restoration. I say semi-direct because these days we've got more options than ever when you've got things like semi-direct composite work or pre-cured composites or ceramic hybrids when you're dealing with milling and CAD/CAM solutions. So I think that world has really opened up in terms of using more robust, harder materials that have great ability to protect the tooth moving forwards. So if I was in excess of perhaps 50 or 60% of the ratio of the tooth to restoration, and I was dealing with a static and dynamic occlusion that had the potential to worsen in a short period of time, I would definitely go for a semi-direct or semi-indirect or an indirect.
Amazing. That's such a nice, clear guideline. And I think a lot of people find these guidelines helpful in their decision-making tree. And again, I appreciate the fact that you're looking at the opposing dentition, the functional risk of the patient and the fatigue that you mentioned as well, of the restoration as well. And that's fantastic. And that leads beautifully to our last big theme, which is how do we manage, Andy, these restorations, which are these huge amalgams? Now we're talking maybe, you said 50, 60%. I'm talking about these amalgams that are 80, 90. Okay, let's go for 80% of the tooth, right? So upper lower molar, 80% of the tooth is amalgam. It's been there for a long time, but we can see signs of fracture. We can see some ditching, and you want to reduce the risk of fracture or catastrophic failure by intervening. The problem is, by intervening, you're not going to have much tooth left. And really, sometimes you think, okay, am I going to remove the whole restoration and commit this patient to a root canal treatment to then put a cast post in this molar? Are there any other ways around treating this, or some guidelines that you use for decision making? Because I have to tell you, Andy, I've shied away many times. I've made a treatment plan for a patient for a quadrant, but I will just work around that upper first molar. We've got that behemoth amalgam because I don't want to touch it. Any help you can give me?
I think the first thing is communication. As we said before, Jazz, we've got to look at communication and have our patient on board. We should not be responsible for owning the clinical problems that a patient presents with. Okay, so it's really essential to every patient that comes our way that we say, look, we are here to assist, we are here to help. Here is the problem at hand. Now, we have a couple of options here, but here are the risks. That's the first thing, because very, very, very quickly it can turn on you. And I hate to go off topic, I apologize, but I think that is so, so important to make sure that you as the clinician don't own the problems that the patient possesses. First thing.
That is key. I love that.
Yeah. The second thing is that by removing that restoration, as you say, when it's 80, 90%, you run the risk of there being so little tooth that there's not anything to work with. So you are already telling that patient that root treatment is a possibility. And if that is the case, how are you going to then restore that tooth with an indirect restoration when there's so little tooth that remains? So there are a couple of ways to look at this. And I guess some of the more contemporary core build-up materials, and I'll include composite within that, are probably a sensible way to then seal the underlying denting, and is as good as anything these days, as the research has suggested, when properly treated. So again, if we were to then carefully and sympathetically remove the amalgam restoration, that doesn't mean going in with a fast handpiece until you see dentine, or worse yet, until you see pink. What I do mean by that is perhaps sometimes using ultrasonic handpieces to then try and blast off bits of the terminal part of the apical amalgam, if you like. I also mean using things like air abrasion to then try and remove the apical amalgam. Whatever you can do to try and be gentle in your removal of that material is a good way to go. And then because you've used something like air abrasion, you're in a good place to then try and hybridize that dentine as well as predictably as possible. Pretty quickly, I'm going to get etch on there and leave it on there for no longer than about 10, maximum 15 seconds, and then use a good fourth generation bonding agent like Kerr Optibond 1 and 2FL, which is gold standard. And then put a core in place. I'm quite happy to build up a composite core in good nano hybrid composite because that's nice and strong. I know then it's well sealed to the underlying pulpal area. And then perhaps you can carry on your prep from there. That's all done pretty quickly. You've got to be in a situation where you can engage the margins of your restoration. So whether that be by using deflection or retraction cord, whether that be sort of some form of deep marginal elevation, whether it be some form of crown lengthening, you've got to try and make sure you can get onto sound margins where possible, especially with direct restorations. And I think that if you can't visualize, if you can't see your margins, then you need to put yourself in a position where you can. And that means either doing one of those things we've just talked about, or then perhaps bouncing it off to someone who can perform some crown lengthening for you or something like that.
I think the main takeaway there in those tough scenarios is all about the communication, because the dentistry we can remove that. And you gave some great tips in terms of atraumatically, if you like, removing these amalgams, which is such a great thing to consider. And then proper protocols in bonding under isolation to build your core, and then considering something indirect from there. But it's all about that conversation in these big amalgam cases. So I really appreciate you not digressing, but really putting the foundation of that entire topic in its place. Andy, you've answered all my questions. I really appreciate it so much. So the main two things I want to ask now is any final words on this big topic that we covered, and where can we learn more from you? I know you run some courses, and I'd love to know about this because I always get flooded. Every time I got a really interesting guest like yourself, people always message me saying, hey, where can I learn more about Andy? So I want to put your stuff on my website, but also what kind of, which countries do you teach in now?
So I guess the first thing to say is that in terms of trying to then make sure that we adhere to good principles in terms of, what the subject matter we were just talking about, it's really, really important that you train appropriately to get to that point where you can prepare the tooth in the most appropriate fashion. If I can just add one more point really quickly, Jazz, is that there's a lot of evidence that supports the use of something like Reliax Unisem as almost like a base if you've removed that amalgam restoration and then sandblasted. The reason is because that self-etch is also dual cure. You mustn't let the dual cure operate by itself because the exotherm is quite high. So you want to light cure it quite quickly. But then you can bond to that because it's a self-adhesive. So from that perspective, that's a good material to use. And then you can then...
So like an indirect pulp cap?
Yeah, basically. Exactly that. So to your question. I own and run a company called Indigo Dent. It's been around for about 4 or 5 years now. And what I do is teaching in composite restorations anteriorly and posteriorly. I've been doing composite education. I'm so lucky. I'm in my 13th year of education now with composites. And I've seen the lay of the land change hugely. I've seen some wonderful talent emerge in the UK, which is just an amazing thing. I really like to see that young talent emerge through. So I do anterior and posterior courses. I launched a toothwear course about 4 years ago, which has been, as I've been told, kind of one of a kind in terms of teaching a lot of the course.
People have been raving on about that. My friend Maria Godfrey, she's always banging on about how awesome that was. I think you do it with Govinda, right?
Yeah, it's one actually that I'm taking by myself these days. But yeah, we started off doing that. But yeah, it's taken a long time to get the course into what it is now. And I've teamed up with Ashley Byrne, who's really helped me out on some individual tooth wear exercises and things like that. But it's a pretty heavy going course, and I warn every delegate to come well rested, because you're not going to be when you come on the course. And there's a lot of theory to go in it, and there's a lot of hands-on, and it breaks through a lot of it demystifies a lot of the stuff that's there, and it makes it work systematically in a workflow that I can understand and I can then put across to the delegates.
Well, please do send me the website and stuff so I can put that on for everyone to check that out.
I will. I will send you the link. It's www.indigodent.com. So then I also offer photography. I've done that for the ITI and such like, so that you can actually get to grips with shade taking, restorations, document your work appropriately, and do ethical marketing.
Fantastic. Andy, it's been an absolute pleasure. And I love that you took this seemingly single tooth issue. And I'm so glad you brought these. I'm so glad. I wasn't expecting to talk about constricted envelopes of function, but I'm so glad we did, because that's another thing that is something that we don't really touch on at dental school. But this basics series in August that we're doing, I'm so glad that you touched on it. And the role of this episode, or role of any podcast, is never to give you the complete info. This is just 45 minutes. So take Andy, what he's saying, as an inspiration to go and read more. Look up John Coyce and the works of John Coyce. There's so much out there that you can learn for free. And then even when you consider going to Seattle or one of Andy's courses, the learning never stops. So thanks so much for sharing that all with us.
It's worth saying that, just because we look at the whole dynamic occlusion and dentition as a whole, it doesn't mean we have to treat the whole dentition as a whole. You can still remain to be single tooth dentistry without having to treat the whole arch or all of the restorations there. So it's just a matter of stepping back and looking at the bigger picture.
And classifying your patient in terms of risk and failure, and having those communication, so great conversations with the patients, which you really help with as well. So Andy, thank you so much. And I look forward to catching you at the dental events, my friend, when they go back up again, running again. There we have it, guys. The first episode of the Back to Basics series of August with Andrew Chandrapal. Thanks so much for listening all the way to the end. Hopefully it didn't get too complex around the whole occlusion and the loss of vertical dimension leading to a constricted envelope. If you didn't understand it, message us. Let me see if we can help you to understand that. Now and again, we're making some helpful infographics. You might have seen that recently. The Protrusive team has expanded. We've got Erica, Chriselle helping me out. We've got the producer, John, myself. So the team's getting bigger. So the announcement really I want to make is that if you signed up to my Splint course early on, and one of the promotions I had is that, hey, if you sign up by this date, then you'll be part of Protrusive Premium. Well, something really awesome is coming to your inbox very soon. So just give me a few weeks, and a really important announcement is coming very soon. But anyway, check out the next episodes. I'm super excited for, in 2 episodes' time, the episode will be titled Regaining Your Confidence in Extractions. This will probably be the most profound episode I've done to date. So I'm really excited for you to listen to that one. But anyway, I hope you enjoy the rest of August. As always, I really appreciate you listening, and I'll catch you in the next one.